because they use more drug and more expensive drug. And I'll tell you what's interesting about this, because a lot of people say, well, that's one report. The GAO did a report earlier this year, and the GAO came to the same conclusion.
Well, the economics are stronger on the hospital side under 340B than it ever was under Medicare, under ASP, in terms of the spread that you can capture by prescribing a more expensive drug. You know, the idea that there is an arbitrage by moving outpatient oncology care into the hospital is well known, and it's well known at this point and well accepted that a lot of hospitals, or some hospitals, were acquiring oncology practices for that purpose. I think it's not impolite to say that. One component of that was addressed with the recent legislation. There's a lot of other components, including 340B. Do you think politically these other pieces are going to get addressed? Do you think the administration and Congress have done what they're going to do to try to address this overall?
No, I think that they're certainly, I would say that a lot of these movements into specialty payment models and just in general this conversation about alternative payment models will address this. So this oncology care model that John's organization is hoping to participate in, quite honestly, it was really aimed at community-based doctors, and that there's a reason for that. And so that's another example, well outside of the BBA, that the administration is trying to exercise to support community-based care for all the reasons Ted said. So I think you can expect to see in either party, whatever party comes into power in 2016, I think you can expect to see administrative actions that further deal with this.
Taking out the drugs, the cardiology, if you look at just the pay, the differentials are bigger on the cardiology side than even the oncology side.
And I'm disappointed as well, too. I agree with you, Kavita, but at least I say this is, and it's a big step.
And I was shocked that there wasn't more reverberation.
When you see MedPAC, when you see OIG, and I can tell you, I had a discussion with a member of Congress just the other day that is looking at this 340B, and actually even on both sides of the aisle, I think it's only a matter of time, because I think it has gotten so big.
For years has been
absolutely, but now you see some other members that you wouldn't expect that have this as an issue and say, this has got to be corrected.
You think patients are aware of this, these site of service differentials? And
no, I don't think they are. I don't think there's good transparency around costs by different sides of care. As a health plan, we've been very proactive in publishing costs for different procedures, elective procedures, shoppable procedures. But site of service is only recently becoming an area where we've begun to focus attention on the cost differentials and even creating incentives for patients to go to lower cost sites of care. Ironically, though, while we may create incentives to go to an ambulatory surgical center, and people and hospitals may label places as ambulatory surgical centers, they bill under the same tax ID, so they're billed as a hospital rather than an ambulatory surgical center.
You know what's interesting is, so United in Oklahoma has done something in terms of incentivizing patients to basically go to that, to literally go to the, in essence, the physician's office than the hospital. And so I think you're seeing, and I've talked to some other payers, you're seeing some movement in that area. And I don't think patients, Scott, understand at all this concept of site neutrality, but I will tell you firsthand, because my email and all my other contact information is out there on the web. I have literally had patients call who go in to see that same physician, same nurse, same building from one cycle to the next, and literally they get their bill and it is sky high.